When we're testing reproductive or sex hormones, we have three options, as with anything: blood, saliva, or urine testing. So when you're looking at those three, they're actually a little bit different from one another. In blood, when you make a hormone like an estrogen, it normally goes around in the blood not as a free available hormone, but bound to things like sex hormone binding globulin. So these proteins gobble up these hormones and transport them around the body. The hormone that actually dissociates from that protein is then available to get into a cell and do what it does. It's also available to get into saliva. So saliva is a measurement of not the total hormone, but the free hormone. Now, can that free hormone get into urine? Not yet. It's not water soluble enough, so when it goes to the liver, it's going to get a water soluble group added onto it. We call these glucuronides and sulfates. These are water-soluble groups that get added onto those molecules. Now they can go into urine. And that's going to be a reflection of bioavailable hormones. So at the end of the day, you have three types of tests, and you're really measuring three different forms of the hormone: the free hormone, the protein-bound hormone, and then the conjugated hormone in urine. But to a first degree approximation, they should tell about the same story. If you're looking at a child who hasn't yet hit puberty, and a premenopausal woman who's in the luteal phase of her cycle, and a pregnant woman, you should get three distinctly different levels of estrogen: a low, a normal, if you will, and an elevated level. And you should see that in saliva, in blood, or in a urine test. Now, once we move beyond that, we can dig through some of the nuances of the testing and see that there are some advantages to some tests over the others. We believe the best way to test estrogen and progesterone especially, and testosterone as well, is in either blood or in urine. So blood testing works very well for these hormones. You want to make sure that you also measure the binding proteins if you can. So not just testosterone, but also sex hormone binding globulin, so the lab can give you a free hormone measurements. Those are really good measurements. When you get to urine testing, you're also going to be looking at those hormones, and then you get the added benefit of looking at the metabolites. So let me give you just a quick example of the benefit of that. Here's a patient who complains of estrogen dominance. So she says, I have symptoms of high estrogen. Now, sometimes that might be because you don't have enough progesterone to balance that estrogen. Her progesterone was fine, but look at her estradiol and estrone. They're elevated. But look downstream. When you look downstream, you can see the metabolites. Now, theoretically, we should be able to see that this woman has a lot of estrogen by looking in blood, by looking in saliva, or by looking in urine. But only in urine can we add the metabolites. And we can see in this case that the 2-hydroxyestrogens are on the lower side. Now, there's something we can do about that. So this patient took some supplements that increased 2-hydroxylation, and look at her results after supplementing with this substance that increases the clearance of estrogen. The E1 and the E2, those are your primary estrogens, they came way down, and the 2-hydroxyestrogens came up. So we're able to look at more in depth at why this patient was experiencing high estrogen symptoms and why her estrogen levels were actually elevated. So that's a benefit of urine testing over serum testing or saliva testing. Now, when we're looking at serum and urine and comparing it to saliva testing, what we find is there's a real benefit in measuring hormones in a body fluid where there's simply more hormone to measure. It's an easier measurement. Let me show you the results of a study that we did. We took a group of women who were postmenopausal. So we know these women are estrogen deficient. So they're in their 60s, some in their 70s, not supplementing with any hormone. And you can see their levels here in serum, and you can see them in urine. They're pretty low. Then we look at premenopausal women in 3 different phases of the cycle. The follicular phase is the first 5 or 6 days of the cycle. Estrogen levels should not be as low as a postmenopausal woman, but they're relatively low. Then if we look at days 19, 20, and 21, there should be an increase in estrogen. Then if we look lastly around ovulation, that's where there's this surge of estrogen, and we even put in one patient who was in the first trimester of pregnancy. So these should be elevated levels of estrogen, and that's what you see in serum, and that's what you see in urine. Now, when we took saliva samples from the same day that the serum samples and the urine samples were collected, and we sent them to 6 or 7 different saliva labs, here's what we found, is that there was not proper distinction between those that have known deficiencies of estrogen and sufficiencies of estrogen. So if you look at just simply the postmenopausal group and the luteal group, that should be normal versus deficient, and we should be able to evaluate that. And in fact, we can. And there's a full 10-fold difference between those two values when we're looking at them in both serum, blood, as well as urine. But when we look in saliva, there's a poor job of differentiating between those groups. And that's really important because that's what we're trying to do as healthcare providers, trying to evaluate someone's hormone balance. We have to be able to tell the difference between those who have appropriate levels and those that have deficient levels. And you can see that serum and urine simply do a better job when we're looking at reproductive hormones. Now, when you're looking at things like cortisol, there's about 10,000 times more cortisol in saliva, and it's a perfectly accurate measurement of free cortisol. But again, when we get down to the estrogens, it's simply very difficult to get a good measurement of the estrogens in saliva when we're looking at people at various levels. And that's going to differ from lab to lab. Some labs do a better job because they have more sensitive assays, and they're able to tease apart a little bit the normals from the highs, and maybe to a small degree, the deficient from the normal. But if you look at the lab reference ranges for saliva, they do a good job of highlighting this issue in that there's a lot of overlap between the ranges. So the premenopausal and the postmenopausal group find a lot of common ground, whereas in reality, again, in urine testing, for example, there's a clean distinction between what's normal for a postmenopausal woman and what's normal for a premenopausal woman. So as we're looking at reproductive hormones, serum testing is usually a very good option to look at those hormones. You want to look at the binding proteins. You're going to be missing the metabolites, and in some cases that's okay, and in some cases you might want to add that by doing a urine test. With the Dutch model of testing, we're able to look at the reproductive hormones as well as their metabolites, and in saliva testing, it's going to be a little bit better for progesterone, but with estrogen in particular, you're probably better off sticking with a serum or a urine test to really define those patients well in terms of where they're at with respect to their estrogens. So when you're testing reproductive hormones, you have strong options with both serum and urine testing. Urine testing having the added advantage of offering the metabolites, but either of those can work very well. And saliva can be an option as well. It's just not going to be as sensitive to give you specific information, particularly as it relates to the estrogens.